Welcome to the AME Grand Rounds, our first ever, and we're gonna see how this goes. So, slide, please. All right. So our objectives for the lesson are to identify the appropriate dispositions for airman medical examinations, identify the policy changes for tonight, psychiatry, cardiology, GI, and ophthalmology, and identify new decision tools for psychiatry. Next slide. So these are that we're going to look at sections that were updated in the AME guide, including psychiatry, cardiology. I'm not going to talk about the specifics that will be in the presentation. GI, ophthalmology, neurology, and some administrative issues. Okay, so Dr. Northrup, Judy, you probably stop sharing for just a minute so they can all see Dr. Northrup.
That's right. I think once I start talking, they're going to see me anyway. So everybody, welcome to the first Grand Rounds. Many of you participated in the seminar or the symposium that we had back in December. And one of the things that we've heard loud and clear from the AMEs is we need to do more routine interactions with you all, particularly when we have major changes in what we have in the guide for aviation medical examiners. In addition, I hope you're all aware of the mental health and medical certification ARC that we had that reported out on the 1st of April. One of the recommendations out of the 24 that we're working on was that we provide better, more timely education to you, the AME. So hopefully everybody saw the new updates for the guide this morning. And we decided we wanted to have these, particularly when we do major modifications to the guide, but we may start doing these more routinely so that you all can ask questions as we even make the smallest tweaks in the guide. So feedback would be awesome. What works well, what you think we need to do a little bit more of, we would greatly appreciate. All right, well, without further ado, because we've made some pretty outstanding changes, some of them in response to what happened during the ARC, some of them we've had working for a very long time, some of them because we're thinking outside the box these days, trying to apply science and what's happening so that we're keeping up with what needs to be done, what the standard of care is. So with that, I'm going to hang around for the hour. I'll watch the questions. I'm going to turn it over to Dr. Dan Danzig. Dan, over to you.
Sorry, Dan, just one thing I forgot to say, and I just noticed that this is being recorded. So if you have an issue with being recorded, you should know that now. So sorry, Dan, go ahead. It's all yours. And Judy, please share the slides again.
Yep. So some key takeaways before I review the disposition table that I want you all to take away. First and foremost, this allows you to clear certain conditions that have undergone treatment, either previous treatment or current treatment. And by treatment, I define previous antidepressant therapy is acceptable under certain conditions, and then previous or current psychotherapy is acceptable for up to 2 of the 11 conditions, which I'll go over and review in greater detail. That's one key takeaway I want you to get from this. Another key takeaway is that this allows you to clear these cases in which individuals obviously have stopped the treatment and are stable enough to go ahead and issue. The other thing to take away from this disposition table, it's a preview to what's coming in the future. So it's actually pared down from what I had before, and the decision tool itself is what what I want you to take out of this is the word uncomplicated. Uncomplicated is a word that we use in psychiatry and psychology to refer to those without significant mental health risk factors. And so that's part of what the decision tool is for. And so in that sense, the decision tool is what's helping us to ascertain that these are either no risk or low risk conditions that will allow you guys to issue.
Some takeaways on this disposition table. Again, it's uncomplicated anxiety, depression, and related conditions. I'll go over the 11 conditions. The right-hand part of this slide, we couldn't fit the entire disposition table, so that's why it's cut off. That's why it doesn't look like there's 11 diagnoses down there. But it's up to 2 of the listed conditions, which I'll go over. If somebody had previous medication management for any of the conditions listed below. It had to have been 2 or more years ago. They could be they may have just had psychotherapy, which is acceptable, and they could also be in current psychotherapy. I kind of reviewed already what the complicated part was, but I'll go into more detail about that with the decision tool that we have. But the other key takeaway is that everything is resolved to your satisfaction. And in block 60, it's critical that you document the summary as annotated on the right-hand column. Discuss the history of, list the conditions that are applicable, no positive screening questions, and no concerns. This is a signal to our analysts and our docs at Oklahoma City that we don't have to ask for any additional information. Next slide. So as you can see, these are the 11 conditions, and we just categorize them by anxiety, depression, and other for simplicity's sake. As you can see, we listed for anxiety specific terms like unspecified anxiety, GAD. We added situational anxiety. And if you see a DSM term, it's the same as adjustment disorder with anxiety, as well as social anxiety. I categorized PTSD and obsessive compulsive disorder into the other group for this disposition table, but those are conditions that each of those would be considered one condition. Under depression, we have unspecified depression, postpartum depression, and then we also have situational depression. And I want to make a note for those that are astute AMEs out there. We still have the old, but it's still there, our situational depression disposition table. In future iterations, we'll do away with it, but for now, you could use either or in this disposition table. You don't have to meet criteria for both. You can use either or. So depending on the type of medication management for that situational depression, you could use the regular situational depression disposition table and then one of these other conditions, or you could use the situational depression under this specific disposition table. And then we also added another condition that it's commonly seen in clinical practice, and that's basically adjustment disorder with mixed anxiety and depressed mood. So that in itself is its own condition, situational anxiety and depression. And then as far as PTSD, we still have the PTSD disposition table in the AME guide. For purposes of this, you can use this or the other one. We actually use the decision tool for this one and replaced it with the PTSD. I'm sorry, we replaced the PTSD decision tool with the one that we have here, so that they're one and the same, for simplicity's sake. We're not asking you to make sure that NARMN meets both disposition tables, like the situational depression disposition table. I'll go over the V codes in the next slide. So these are just some examples, but this provides you greater guidance on what we allow for either V or Z codes that you guys could clear. It's not uncommon that individuals get prescribed medications for these sorts of issues, or they're just in therapy. What is very common, as you're well aware, is the upcoding that therapists may use to be able to bill insurance for these very V code conditions. And so that's why we wanted to add it to this disposition table. If you have to zoom in, go ahead and zoom in on this, but this is a snapshot of the decision tool that we're using for this. This is basically what everything has to be in the note column to be able to issue at your level, otherwise defer. And all of these are what we would consider, the majority of them consider risk factors. In future iterations of developing this disposition table, we'll have a separate behavioral health risk factor summary sheet that will be separate from the decision tool. But some of them are included here that we want you guys to go over with this decision tool. So such things as suicidality, other specifically disqualifying conditions, such things obviously as psychiatric hospitalization, certain treatment modalities like ECT or TMS. We don't want you guys issuing any history where they may have been involuntarily evaluated. Or even undergone court-ordered treatment. Those kind of things would bump somebody off of this. And then what's critical with this decision tool is if an individual has had more than one episode of symptoms that has required treatment, It's not uncommon. Some individuals may have something like generalized anxiety disorder that's unmasked through stressful times in their life. So they have it off and on and it require treatment off and on. For right now, we don't want you guys issuing those. We want you deferring those. Future iterations, we'll have a way to get past that at the AME level, but right now we want you to defer those. And same thing with multi-agent drug protocol use. So under this disposition table, you guys can only clear monotherapy for previous medication 2 or more years ago. We provided some specific guidance in there that you could, it can allow for subsequent trials as long as it's monotherapy, either because of side effect reasons or to get greater benefit or efficacy, but it still has to be one medication trial at a time. And then, of course, we included a couple of questions in here, like number 7 and number 9, that allows you to use the AME to make a safety risk assessment, right? If there's such symptoms that you don't think are resolved, that should be resolved, that may impact flight safety related duties, that would be something to look at there. That may not allow you to clear that specific airman. This also would be for your comfort level. We're not obviously asking you to be like if you have a concern that somebody had major depression, even though they're trying to tell you it was a situational depression, but you're not convinced. Right now, we're not allowing you to clear that. Future iterations of this disposition table will have some additional limit guidance on how to do those ones. But for right now, we want you to defer those. If there's any question of a mood disorder like dysthymia or MDD. And then, of course, the last one on this decision tool number 9, if the treating clinician, if the therapist, or you have any other concerns, this is similar to what we've done in other disposition tables that allow you to defer. Next slide. So this is just some additional instructions on the decision tool, which I've already gone over. Everything falls into the no clear column, allows you to issue. Any one of those is a yes, you'd have to defer. The decision tool is for your use. Obviously, you guys know as AMEs, have you seen decision tools before? It's not required to be submitted, but you could if you wanted to, but we're not requiring it. Next slide. If you're deferring, this is some of the additional guidance to go to row B. Again, what you see here is about a 30% solution of what you're going to see. It's going to be a more expansive version of this in future iterations of row A, B, and C. And I'll be doing away with some of the other disposition tables, including the antidepressant protocol. But for right now, if you see any of these anxiety or depression or related conditions, or it meets these criteria, and you have to defer to assist us at either AMCD or headquarters and provide a reconsideration criteria, or maybe going ahead and allowing for a special issuance, we would need a detailed clinical progress note to assist us with that. And again, these would be covered instances where somebody was even previously on a special issuance or special consideration for SSRI use. For right now, we don't want you guys clearing those because somebody may have, for some reason, dropped off our radar, being on an SI for an SSRI, and then gone 2 years without it, and then want to come in and see you. For right now, we don't want you to clear those, but I have a future step on how to do those. Again, any type of recurrence, episodic of symptoms, whether either they try multiple medication attempts to discontinue or stay off medications for what we're unable to. They may have had multiple trials of psychotherapy that were unsuccessful over time. And of course, anybody that's required dual or triple or other type of therapy, you'd not be able to clear. And again, any concern for MDD, clinical depression, or persistent depressive disorder, dysthymia, we'd want you to defer. Next slide. So just to summarize, the main things I want you guys to take out of this is we're not as concerned about running down the exact diagnosis for these related conditions unless there's risk factors, right? If you can obtain, and this is obviously the challenge, if you can obtain a good enough history that makes you confident they meet this disposition table, we don't need you to submit clinical documentation to support that. If you're in doubt, then it's up to you to obtain that clinical documentation and run it down. we're not trying to prove the negative here with every single case, because we know that there is the DSM itself has been criticized rightly, having poor inter-rater reliability for psychologists and psychiatrists. So if it's an unspecified anxiety or a GAD, it's not as important. What is important is that there's no risk factors, that you feel confident there's no comorbid substance dependence, psychosis history, suicidality, et cetera, et cetera. Again, future iterations of this will even clarify some of those things a little bit more. They allow you to clear individuals that even are in current medication management. But for right now, we want you to be able to clear uncomplicated cases. And the point of this is that they've actually sought and obtained treatment. We don't want individuals now not reporting they're in therapy, because this allows you to actually clear them while in the therapy. And it allows them to basically report that to you and be cleared. Next slide. So last bullet point I'll put out here for education, and of course I can take questions at Dr. Fraser's, depending on when she goes over the cardiology updates. We have a new 9-box for the psychiatry branch here at headquarters. This is something to assist whether it's you out there want to send an email, generic question about anything, specific case with some identifying information. Allows me to triage these requests to be able to make sure we get a return reply to you. It also allows airmen, air traffic controllers, they can use this 9-box email to send us questions. We currently already have a phone number that's listed in there for headquarters. This is just another tool to help us triage these kind of requests in one place, and allows me to be more efficient as far as our branch to get an answer back to the individual. Could be another stakeholder as well that has questions about our policy. Pending your questions, that's all I have for now.
We want to thank Dr. Danzig, but we're going to go ahead and move on to cardiology, because there were a lot of cardiology items that have changed. So, Dr. Grassley, it is all yours.
I'm Dr. Cindy Gressel. I work in AMCD at Oklahoma City in medical appeals. So we had our cardiac Knights of the Round Table meeting back in March with the goal of trying to streamline some of our certification for cardiology symptoms. And so this is going to be a brief summary of some of the things that we were able to get pushed through. So I'm really happy to get to report all of these new changes. It will be a change for everyone, and we need to get used to it, and our reviewers will need to get used to it. So I understand the question, whoever posed the question about, rolling this out and getting used to the change, because we're there too. So we're going to work through it. Here is a slide, and it's just kind of a brief overview of the things that we were able to get changed. For coronary heart disease, after they've been through their initial certification, we still require all of that testing prior to initial certification. But when they're being recertified, we no longer have to do a routine stress test. We created a worksheet that is going to focus specifically on the risk modifications in accordance with the American College of Cardiology and American Heart Association for risk factor modification. And as long as everything looks good there, we can certify them on an AASI with no routine stress testing. So that's huge. We're hoping that we'll be able to get our pilots through that recertification process a lot quicker. We also removed this stress testing for cardiac valve repairs and replacements. It was thought that the stress testing is not really adding to anything that would be a surrogate for that functioning of that valve to look at that. So we were able to get rid of that requirement. We changed up the certification for our pacemakers. If you'll recall, previously our pacemakers were certified annually until about 18 months of battery life left. And then they were certified every 6 months until they reached that point that they had only 6 months left on their battery life. The problem with this is that they're no longer certified at that 6 month point. However, their insurance would not cover the battery replacement or the generator replacement until the elective replacement indicator, the ERI, until that point was met. And that's typically around 3 to 4 months of estimated battery life. So we changed our certification. We're going to certify them right up to their ERI. So if their ERI is in June, we will certify them up to the 31st of May. So that'll be a good thing for them. They won't be in that limbo period where we haven't certified them. However, their insurance will not cover the battery replacement. And these are so expensive. So we don't want our pilots having to go through that. We removed the requirement for fasting blood glucose and replaced that with the hemoglobin A1C because we all know that this is more indicative of how your blood sugar control has been over the past few months rather than one single point in time. And someone had posed a question about EKGs and asking if we could use the Cardia Mobile or some other kind of form like of a 6-lead EKG. Unfortunately, we have to stay with the industry standard, which is the 12-lead EKG. And unfortunately, that's where we're at right now until technology catches up with that. And then we'd have to readdress that at some other time. Here is our AASI that is modified for coronary artery disease. Basically, the pilots that have already been through the certification process and they're working on their recertification, they will go to their cardiologist. They will have all of their risk factors annotated, and if they're in good control, and we don't have any of these concerning factors that are listed under the criteria that you would defer for. As long as everything looks good, they haven't had any other further symptoms, no other hospital visits for any kind of cardiac related reason, no new events or anything like that, and their lipids are under control, they're on appropriate medications, then they can be followed with an AASI with no stress test requirement. Now, if they have had any of these issues, or they're not under, their lipids are not under perfect control just yet, they're working on it or whatnot, we can still follow them with a stress test, and we would place that on a special issuance at that time. Whatever stress testing would seem appropriate for that individual pilot. This is our brand new status summary worksheet that the pilot will actually take in to the cardiologist, their treating cardiologist, and they will annotate, their risk factors, their blood pressure, what is their LDL, what is their A1C, are they under good control, are they following the guidelines, which are right there in the middle of the page, the 2023 AHA and ACC guidelines. You can actually link on that. And that's where you will find documentation that supports these decisions, such as no stress test. Stress testing was not shown to be beneficial in reducing morbidity or mortality in chronic coronary artery disease. So we're not going to do it. And as long as everything else looks good, they'll turn this form into the AME, and you can issue as an AASI. And here are the actual questions that are being asked. Are they at goal on their lipids? Is their blood pressure and A1C at goal? Any symptoms? Or, like I said before, if they've had any kind of new events. And then finally, does the cardiologist recommend them to continue flying? Are they happy with their cardiac care and whatnot? If anything is in the negative, then we're not going to be able to issue them on an AASI. That'll need to be deferred, and then we'll need to gather more information. Here's just more of a how many times are we going to say this? Pacemakers. Okay, here's what we had talked about a little bit in the beginning. We'll have it's now based, instead of the battery replacement, it will be the elective replacement indicator. I always have to look that up, ERI, and that will be reflected in the new pacemaker status summary worksheet. And removed the exercise stress test for routine valve replacements and repairs, even on initial and for research. And 12 leads, again, needs to be a 12 lead standard EKG. And we're using an A1C now instead of a fasting blood glucose.
Super. Dr. Grassel, thank you for all your time and for answering all the questions. Any questions we didn't get to, we'll give back to you, and you can help us come up with an answer and get it back to the AMEs.
Yes, ma'am. Thank you so much. I appreciate it.
Super. Thank you very much. All right, last section. This one's pretty fast. I know we're getting kind of low on time. So just some specific conditions that were updated today. One is gallbladder disease. We know you see it all the time. Previously, we had very truncated guidance. A lot of what we're doing is going into the asymptomatic versus symptomatic realm. So if they're asymptomatic, they had surgery, they're fine. Put those notes in block 60 and issue. We only want you to defer somebody who's got symptomatic biliary colic, somebody who's had surgical complications that are persistent. In a lot of times, it's usually about whatever the persistent complication was. Those are the only ones you would have to defer. If they had a complication that is not otherwise disqualifying, that's one of those ones, a lot of times you'll be able to issue those. So just see what the complication was. Next one is ophthalmology, lattice degeneration. You're starting to see that a lot more on your reports because we're starting to see it a lot more on reports. Our fast eye doctors tell us it's because the cameras pick up so much of the periphery now. They can see things much better, much more. They come into play much easier. If you see lattice degeneration that did not need treatment with laser and definitely did not need a surgical treatment, if they're not having flashers, floaters, or decreased vision, and they meet the vision specs for their class, you can go ahead and issue. Just put that information in block 60. Anybody who has flashers, floaters, does not meet vision specs, if they had some kind of laser repair to this lattice degeneration, that throws it into a different category. For them, you will need to defer. We need the note from the ophthalmologist or the optometrist. On our standard wording, you'll notice that we ask for meds. We know these aren't treated with meds, but it's one of the standard questions that we ask. We also want to know what is their best corrected vision at the optometrist or ophthalmologist office, and send copies of any testing that was already performed. All right, a couple of other ones. The entire neurology section was updated January of 2023. That we hope is working well for you all. Gives you a lot more information. There are some neurology conditions you can actually issue. If you have to defer a neurology condition, you should at least know what we're going to ask for. Specifically on brain tumor, it used to require a vascular neurologist. We no longer require a vascular neurologist. It's their treating neurologist. So that's been adjusted. The letters and blurbs have all been updated to reflect that information as well. And then finally, some of the AMEs at one of the sessions asked about the AMCS limitations. They're in AMCS. They're organized by number. We have gotten lots and lots of comments from AMEs to organize everything by body system. We know AMEs, we know physicians think in systems. Is it a cardiac thing? Is it a pulmonary thing? Is it a nephrology thing? What was entered into the AME guide was just a request from AMEs who said, hey, put the limitations by system so I can find it quicker. That's all this is. The actual record that you have to use is in AMCS. This is just kind of a little bit of a cheat sheet. So just know that that's in there, but the actual record is in AMCS. All right, this is a plug that we like to always give. If you have ways that we can improve the AME guide, this is a mailbox that you can send suggestions on how to improve the AME guide. Just remember, it does not answer any case questions.
As I said at the beginning, this is the first of. We'll do some more of these. Hopefully this was helpful. Again, send us comments. Sorry we didn't get to all of the questions in the chat. Hopefully we got to a adequate sampling of that. A couple of us may hang on for just 5-10 more minutes to answer other questions, but we appreciate everything you do. We are trying to make this better and easier for both you and the pilots. As Deanne said, we are certainly open to recommendations. If you have any for my pilot minutes, I'm still looking for things there. But otherwise, thank you very, very much for your time and attention. Had 219 people here. So fingers crossed we get the word out to even more people tomorrow night. If you have an AME friend that wasn't here tonight, we're doing it again tomorrow at 9 p.m. Central Time, so 10 o'clock on the East Coast. All right. Thank you all. Have a great evening.